so you can be done with me on time. We'll go ahead and get started. Thank you for coming out this evening. When you put on any kind of a public event this time of year, it's always a question, is it going to be 20 below and snowing sideways, or is it going to be 60 degrees and still sunny at this time of day? So I guess we're on the good side. So I want to thank you for coming out, especially during a pleasant evening, to hear a little bit more about your community hospital. I'm Dr. Steve Potler. I'm the Chief Executive Officer of St. Genevieve County Memorial Hospital, and I've been in that role since August of 2020. Before I do anything else, can everybody hear me okay in the back? Okay, good. So a couple of notes. One, this is not a forum for candidates for the offices I'm going to talk about, so this isn't that kind of informational session. KSGM, the League of Women Voters, the St. Genevieve Herald do a great job of talking with candidates about that. So we're just going to stick to what's happening in healthcare these days. A couple other notes. I mentioned that my honorific is doctor, but I am a biomedical ethicist, doctoral trained, not a physician, so I can't prescribe anything. But it came in really handy during COVID. And another, just a personal note, is that I'm about 15 miles away from the farm I grew up on in Ellis Grove, so this place has always been in my heart and in my presence and in all my Christmas vacations around here. So just a couple notes there. All right, next slide, please. So starting out with our message today, there's a lot of questions about what's going on in the area in particular. And I'm going to cover some more detail about what's happening with the big systems that are coming into our community and the challenges that small hospitals have. But just to reiterate that independent status is a priority of our board. It's been true since 1964 when the election happened to vote in the need for a hospital district and a tax on local residents. And when the hospital opened in 1969, and for all of the years since, it's been the idea of we want to make healthcare decisions by local people for local people, and that's there's still a profound commitment to that. Rural healthcare is changing. I'm going to talk a lot about how it's changing, and we're trying to grow to serve the community, and there's a lot of things we're doing to try and make that happen. We want to share the current status of your local healthcare organization, because with all these changes, we want to let you know what's good and what's challenging to us in particular, in addition to all the things that are happening regionally and nationally. Next slide, please. And we do need your support. Never been more true than now. I start out all my presentations with our mission statement that we put people first by providing excellent, personalized, and compassionate health care. And tonight we're really trying to put you in the community first when we talk about we put people first, so that you can make informed choices when it comes to voting for trustees, so that you can be prepared to ask them questions as they're campaigning if they do that, and so you can know a little bit more about the hospital as we go through things. So I mentioned the Board of Trustees a couple of times. Next slide, please. One other note, I think I mentioned this on the radio today, but the last time we did this, it lasted about an hour, and there was about a half hour of questions. And then for those who were more curious, I stayed as long as there were questions. So you can plan for about an hour, so it'll get you to sundown, but it's not going to get you to midnight. It's way past my bedtime, too. So when we use the mission statement at the beginning of every board meeting, it's painted on the wall in the boardroom and in other places in the hospital, and it really is how we measure our decisions. And it's something that we consider to be very important in our everyday life at work. Next slide, please. I mentioned the Board of Trustees a couple of times. We have several here this evening. There are a couple who couldn't make it this evening. We've got Rod Shear, who's been on the board for almost 39 years and our board chair for almost all that time. We've got Mark Fowler here, who's been on the board for almost 25 years. Mark has got just an immense amount of service, and he's decided that he's not going to run for the board this time. That's why there's an open board position in the upcoming April election, and there are two folks who are interested in running for the Board of Trustees. That panel has been open and closed, and so just be thoughtful about your vote there. Kurt Bosler, who's been on between 15 and 20 years now. Veronica Charlo, who's been on for a little over 15 years. And Bruce Giesler, who's been on for almost 4, but before that he was on the foundation, the fundraising foundation, the Friends Foundation, for several years beforehand, so he's got a lot of commitment here. But every one of these people is making decisions about the community, for the community, for the long-term good of the healthcare of the community. And so I'm very blessed to have this group of people to work with as a board. Next slide, please. And we have several members of our leadership here this evening. So there's a picture of me when I was a little less fuzzy. We've got John Schmidt, who's our Chief Financial Officer. Many years in that kind of a role, and a CPA as well. Jennifer McBride Hobbs, St. Genevieve native. She's our Chief Nursing Officer and has had similar roles of responsibility elsewhere before coming back home. Sherry Hanby Vance, who's our Executive Director of Human Resources, very experienced Human Resources Director, and has worked in several other industries as well, including mining, which is kind of handy for knowing the community here, and she's also local. Herschel Parker, who's been with the hospital almost 20 years in various roles, and is our Executive Director of Quality and Risk Management. Allison Richmond wasn't able to join us this evening, but we do have Terry Thomas, who's our new Foundation Director. She's just been named, not even really all the way in her office yet, but we're thrilled to be working with her in a new role. She has been working with the hospital in materials management and has a real passion for helping the organization succeed, and we're going to give her a real chance to do so now. Next slide, please. So there's a lot of things that we've been doing. So I mentioned 1964 and 1969, but during the whole history of the hospital, there have been a series of improvements over time. So 1973 was the first hospital addition because there was a lot of growth and a lot of opportunity there. In 1993, there was an addition for administration and boardroom and clinical space. 2001 was a big year, not just because of the space odyssey, but also because of expansion into oncology. And we've been working with Dr. Liss for most of that time. He's retired, but his legacy of taking great care of people with cancer is continuing with us. Also in 2001, the first Bloomsdale Clinic, we expanded into the point-based clinic, assumed ownership of Riverview at the Park for a few years. We converted to private rooms on Med-Surg. That was a big change as well. The hospital here was designed by the same architect as the hospital in Chester where I grew up. So when I walk down that old Med-Surg, I know how that all worked and how that was all set up. I can tell you where the ice maker was without opening my eyes because I worked the floors enough. And I can tell you that served its purpose, but in 2024, that would be a really cramped space. And fortunately, we've expanded into a new emergency room and a new medical surgical unit, the ER in 2008, and the new medical surgical unit that's on the top floor of the newest expansion of the hospital, and then Pine Drive Medical Center, that's the clinic that has a lot of different services in it in 2020. Very pleased to have that. So you can see we're not sitting still, and we plan to make other changes and expansions and remodelings through time as we go. So next slide, please. So I mentioned the idea of a hospital trustee election, and at the back table we've got some handout materials from the American Hospital Association. So those are some definitions of what a trustee is and what they are supposed to do in that role. And the board has 3 legal duties: a duty of obedience to the charitable purpose, so we're not going to open an animal shelter, we're not going to do other things that may be good things to do, but that don't meet our mission of taking care of the health needs of the citizens of St. Genevieve County. A duty of loyalty to the organization, so don't do things outside the organization that are going to harm the organization. And a duty of care, so show up to the meetings, read the board packets, ask intentional questions that challenge management to make sure that we're doing things that are going to be in the best long-term interest. So next slide, please. And then some of the other board roles, including establishing the ends and goals of the organization. So we want to be in that top tier of performance in quality and safety and patient satisfaction, for example. Making policies and decisions. So we want to have a certain number of physician providers or a certain diversity of specialties so that we meet all the needs of the community. Oversee performance and exercise accountability for results, and build relationships with the organization's key stakeholders. There are things that I can see and things that I can do, but when you look at the experience and the background of our board of directors, they go different places, they talk to different people, they see different things, and people in the community can approach them and say, hey, what about this? What's going on with that? Or, hey, I had a concern, or hey, I want to pass on a compliment. They'll see and touch different parts of the community than anybody in management will. And so those are essential roles for us. Next, please. Some of the responsibilities of the board include provide for excellent management, approve strategic direction and monitor performance, ensure the quality of the medical staff, build relationships, as I mentioned, ensure compliance. Healthcare is an extraordinarily regulated industry, and so they have a responsibility to make sure that we are doing our duty to meet all those expectations, and to ensure clinical quality, patient safety, and customer service, and board effectiveness. Next slide, please. And we have a great looking group, and I'm showing them off as much as I can, and so we're glad to be able to work with them. A couple things about our area and what's happening in our region. As you can see, the St. Genevieve County Health Rating, so how our community rates compared with other communities, lighter is better. And so St. Genevieve is actually in the top 25% in terms of health ratings in the state of Missouri. And you look down here towards the southern Missouri and the boot heel, there's a lot more health challenges in those areas. Next slide, please. And then when you look at health outcomes, like how long people live, how long people can stay in their own homes, education level, what the average income is, St. Gen, again, scores very well. It's a lighter color compared with the rest of the state, and so you all are doing a great job at keeping yourselves healthy and preparing yourselves for your futures to be with your families for as long as possible. And then one of the things that is a real scourge in the nation right now, when you look at it, last year there were over 100,000 deaths from opioids, most of them from misdirected prescribed opioids. And so when you look at the threat of what happens when people misuse and overdose on opioids, there's a real threat. So once again, darker is poorer performance. St. Genevieve is scoring very well compared with the counties around us, and that's something that we're very zealous to maintain. And I know that Herschel in particular has been working with the pharmacy for a long time, and so the idea of how our physicians prescribe opioids has been something that has gotten a lot of attention over the last 10 years. And so we've dramatically reduced the amount of opioids that are prescribed. We're rigorous about when they're used, making sure that the people who need them get them, and when they don't need them anymore, that we help make sure that they can transition to things that aren't as addictive and aren't as dangerous to them. So we do want to maintain the health status of our community. That is what we are here to do. Next slide, please. I mentioned rural health has particular challenges. When you look at the country since 2005, there have been almost 200 rural health closures since 2005. That's a huge number. So there are roughly 5,000 hospitals in the United States overall. When you look at, there are about 2,000, or there were about 2,500 hospitals in rural areas, and that's been reduced by about 200 in the last 20 years. So there's reasons for that, and we'll talk about that a little bit as well. Next slide, please. So when you look at what happens in Missouri with closures and consequences, Obviously, when a hospital closes, you lose access to care. You lose access to emergency and inpatient care. You lose the providers that depend on an acute care hospital. So for example, if the hospital closes down, surgeons leave, obstetricians leave, lots of other physicians will leave the community. And I'll talk about the effect of the salaries that has over time. Then loss of other local health services. So other types of health services may not serve the area if there aren't the physicians there to write the orders for them. There are some direct costs like the loss of jobs. These are good paying jobs throughout the organization, and we're one of the largest employers in town at over 500 employees. Loss of taxes paid by the hospital and employees. So in this case, we're not for profit, a government entity, so we're not paying in taxes generally, but all of our employees pay in taxes. And then the loss of jobs and revenue if businesses leave. Very often, businesses will not go to a community that does not have a hospital. Very often they will not stay if the hospital closes. Very often retirees will move out of the community because of the security that having a local hospital provides. And younger families want to plan for their future lives, and if they don't think that they can have a hospital locally, they'll relocate. And so those are some of the risks of what happens, and this is what's happening in those 191 communities where the local hospitals closed down. Then there's other indirect costs. When you look at travel costs for poor, elderly, disabled, and other patients. So if you get someone who has to travel 30, 50, 100 miles for care that's been available locally, that's a huge burden on the local population. We've been trying to get a neurologist here for several years because the neurologist who was coming to town relocated out of the state. And so we have people with Parkinson's that now have to go to St. Louis or Cape Girardeau when they used to be able to get seen here. And some of these people, when they called up for an appointment, they were told, we'll see you in March 2025. Whoa. So when I go to the groups like that, if we have other people leave, it's harder and harder and harder to establish those professional relationships. And then the increased cost of attracting teachers and other workers, it's more difficult to get and keep teachers here as well. Next slide, please. So there are a lot of financial challenges for rural hospitals. So independent hospitals have lower reimbursements. So when you have a larger hospital or a health system, and if you are negotiating with Aetna or United or Humana, and you're negotiating with them and you say, we take care of 200,000 of your patients, 500,000 of your patients, 1 million of your patients over our entire span of the system, you've got negotiating power that I don't have. We're basically in the county, and that's, I'll illustrate that in a few minutes. And that's, so we don't have negotiating power. We have minimum costs. So for example, if we have 15 births in a month, that means there's a lot of days where there are no births. But we have 2 labor delivery trained nurses in the hospital at all times, because if a woman comes in at 20 weeks or greater pregnancy with unspecified abdominal pain, they go straight to labor and delivery first. They're assessed by those experienced labor and delivery nurses. And so we have to keep them around the clock just in case. Same thing with the emergency department. Compared with other places, it's a lower volume, but we have to have a physician immediately available at all times. And 2 registered nurses is what we've staffed it with. So there's some costs that aren't efficient that are necessary. And so that changes things for us as well. Bringing in new technology is especially costly with a lower patient volume. So for example, if we have a scanner, the MRI scanners and the CT scanners in the bigger hospitals in St. Louis are running 24 hours a day, because that's what the backlog is, and a lot of times they don't do the inpatient studies until the middle of the night because the scanners are full all day long without patients. Here we generally run them 12 hours a day for scheduled patients, and then we have techs in overnight for emergency call. Rural hospitals have a population that's older and sicker than urban areas, and I'll demonstrate that in some slides coming up. And with 5 or more comorbidities, it's not hard to get there. So you've got gout, you've got high cholesterol, you've got type 2 diabetes, you've got all these other conditions, and your cost of care is going to be twice as high as other places, which makes it harder for them to afford care. Lack of transportation, that's one of the biggest challenges of all, because we don't have Uber, we don't have a lot of other services, and SMTS does its best, but they're on a scheduled basis, and it's a challenge. So those are some of the challenges. Next slide, please. And small hospitals are at risk, as we mentioned. 191 small hospitals have closed since 2005. 15 of them have been in Missouri. So that's a lot for our state to lose. And in the whole state, there are 161 licensed hospitals. 67 of them are rural. Only 28 have OB services, and 31 are critical access hospitals. So critical access hospitals tend not to have OB units because of those inefficiencies that I mentioned before. And so we're one of only 28 of those rural hospitals to have OB services. So you look at that, and we're really fortunate in that regard. And then you look at local hospitals with affiliations. So this is kind of our catchment area, our neighbor hospitals here, and I've got another illustration of that in a minute. Madison Medical Center in Fredericktown is managed by SSM out of St. Louis. Parkland and Bonne Terre are owned by BJC. Perry County Memorial Hospital is now Perry Mercy Hospital. Southeast Health is now Mercy Hospital Southeast in Cape Girardeau. Washington County Memorial Hospital is now Mercy. St. Francis and Iron County are currently unaffiliated, but I've been hearing rumors of Iron County looking for a partner for a couple of years now. So we'll see what happens there, which leaves us as just about the only independent hospital on this side of the state. Next slide, please. And I recently found a map of where the independent hospitals are in Missouri. And it's an eye chart, I know, so don't worry about that. But where you see these little black blobs, the little black blobs are where the independent hospitals are, and the white names are just the county names. You see very few independent hospitals on this eastern side of the state. More of the independent hospitals are on the western side of the state. I think that's because the hospitals and systems consolidated faster in St. Louis and took over, rapidly gobbled up market share. And so that's why they've consolidated all of the bigger hospitals and as many of the smaller hospitals as they thought made sense. Next slide, please. Then when you look at our service area overview, so here we are. So in St. Genevieve County, there are about 18,000 people in the county, and the people in these zip codes here are really more aligned with Farmington in terms of where they work and where they shop and where they seek their health care. And so that's about 2,000 people. And then the other 16,000 in St. Mary and St. Genevieve and Bloomsdale zip codes tend to come towards our hospital first. But then you look, Perry County is with Mercy, Madison with SSM, Iron County is independent, BJC, Mercy, and so we've got alignment with systems all around us, and we are still independent because of a lot of good decisions with prior administrations and a board that's been consistent. Next slide, please. I mentioned that typically rural areas tend to be older, and older people tend to have more things go wrong with them. That's how the system is set up. So when you look at the youngest group, the gold bar is St. Genevieve County, the blue bar is Missouri, and the black bar is the United States. So we have fewer people in that youngest cohort than Missouri. We have fewer people in that 18 to 44 age range than Missouri. We have more people in the 45 to 64 age range than Missouri, and more people in the 65 and up age range than Missouri. So we are a little bit older, even though we do look pretty healthy. Next slide, please. I'm going to try and clear my throat. I know I'm coughing way too much tonight. So, I mentioned declining revenue. Approximately 40% of rural hospitals have a negative operating margin as of 2023. And unfortunately, we're one of that 40% as of right now, and I'll get into some of why and some of what we're doing about it. Labor and supply costs have increased 18 to 20% since the pandemic. So there are some things, just because it's hospital equipment, it's always a little more expensive, but it's really ramped up in the past couple of years. So things are increased by 30, 50, 100% over what they were just a few years ago. Labor costs, in the past couple of years, we've given at least 10% pay increases with our employees, and during COVID, a lot of the federal money that came in for COVID payments went straight to our employees. I estimated that about $10,000 per employee went out from the COVID funds that we got from the government. So we're trying to keep our staffing stable. Contract labor charges. There for a while, there were a lot of nurses who were quitting their regular jobs and going and working as an agency nurse, a temporary contract. And those some hospitals were paying $200 to $250 an hour for those nurses that they were probably getting paid less than $50 an hour, $40 or $50 an hour in their day job. And then when the crunch hit, the charges to the agency went up to $200 to $250 an hour. We never paid that much, but a lot of small hospitals got into a lot of financial distress because of that. And Medicare and insurance plans are only increasing payment by 2 to 4% per year. So if your employer is charging you 10, 15% more per year, we're only getting 2 to 4% per year out of that. So I don't know where the rest of it's going, but it's not coming to the hospitals. And the prevalence of high deductible health plans and Medicare Advantage plans, Medicare doesn't quite pay what it costs to take care of Medicare patients. That's true in small hospitals and large hospitals. Large hospitals tend to spread it out over the privately insured patients to make up the difference. When you're in a small hospital like ours, there aren't enough other plans to make up that difference. And so Medicare doesn't pay as much as it costs to pay for health care for their patients. Medicare Advantage plans pay a lot less. So our percentage of Medicare Advantage plans went from about 7% 2 or 3 years ago to 25%. Now, obviously, the patients are getting a less expensive health plan, and they're getting some other benefits as part of the health insurance plan design, but the insurance companies are directly taking that away from the doctors and hospitals when they need care. So that's a challenge there. So you see where the difference is. It's not that we're doing something different, it's that the way the world works in my world is changing. Next slide, please. Another issue is things like patient bypass. So when you're a smaller hospital, there's a perception that you're less capable. One of the challenges that happens is if you come up with a new symptom or you're worried about a health condition that runs in your family and you look it up on Dr. Google, and then you're going to see a shiny, friendly ad from Big System X in St. Louis, and you're going to say, well, I think I'll go with that one. And you're not checking with our hospital. Our hospital, I'll say, is uniquely capable in terms of the mix of services that we have available, that sometimes even people who've lived here their whole lives say, I didn't know your hospital did that, even for services that have been in place for 20, 30, or 50 years. So, critical access hospitals are even more likely to get bypassed. Critical access hospital is a designation by the government. It's smaller hospitals, 25 beds or less, with a relatively short average length of stay of 96 hours or less. And at the end of every year, Medicare takes a look at what it costs to take care of Medicare patients compared with what they paid you, and they do a partial settle up for that every year. So that's what critical access means, and that's what you'll hear me talk about sometimes with our hospital. The next slide, please. And a little bit more about our operations and finances. I mentioned, next slide, please. We are uniquely capable in some ways. So a lot of these small critical access hospitals may have 2, 3, or 5 physicians on staff, not anywhere near the specialties that we have. So these are the full-time specialists that we have, some of them. Emergency medicine, obstetrics. Transitional care is a swing bed program. So one of the things you hear from a lot of folks is that I got discharged too soon, before I was ready. One of the advantages of being a critical access hospital is we have a program that the feds call swing bed and we call transitional care that lets people stay a little bit longer, get the rehabilitation they need, get the exercise they need, and fully recuperate to where they can go home and live independently. As I mentioned, cancer treatment, and we do have some research protocols from time to time, that last stage before it goes on the market where it's safe to use in humans. They just need to increase their study numbers a little bit, and so we participate in those from time to time. Diagnostic imaging, we have the most up-to-date imaging in our available. Actually, our MRI was the first one of its kind delivered in the U.S. when it came out because of the sophisticated technology in it from Philips, a reputable company. We've got a great lab, respiratory therapy in-house 24 hours a day. That almost never happens in hospitals our size. Several clinics, and I'll go over the clinic sites in a few minutes. Primary care, we do have visiting specialists and walk-in clinics. I like to point that out because a lot of systems will have something they call urgent care, which is basically a slightly enhanced clinic that they try and charge you emergency room deductibles for. And our walk-in clinics charge clinic level deductibles or co-pays, and so that's a significant savings to the community. If you just need care today, it's not the end of the world, but my doctor is pretty booked up and I have a sore throat and I'd like to get looked at. Happens all the time, dozens of people every day, and we can charge you a clinic fee, not an emergency room fee for that. And cardiopulmonary as well. Next slide. Surgical specialties, that's where we have really robust services. So we have general surgery. We just brought in a new Mayo-trained young physician, Dr. Salim, and he's taken off and does great work. 2 OBGYNs and 3 nurse practitioners in that specialty. Dr. Cavens is renowned for her breast surgery. Orthopedics, we have 3 physicians coming here. Podiatry, we've got a full-time podiatrist. Gastroenterology, urology, Dr. Enger has 2 full-time nurse practitioners that work with him. Ear, nose, and throat, 2 physicians who do that. Ophthalmology, I didn't want to mess up ophthalmology and then have somebody make fun of me, so I didn't put that up there, I just put I. And then pain management. So we do have a lot of surgical specialists that come visit us. Next slide, please. When you look at the financial effects, I mentioned our employees, so we have 365 full-time equivalents, but over 500 total employees. That's a lot of folks in this town. We have 19 full-time physicians. As I mentioned, a lot of towns our size will have 4 or 5 physicians total. 26 nurse practitioners. The county tax support of just over $1 million a year. And our net revenue is about $68 million last year. So we appreciate on the county support, but that's probably not going to be a make or break difference for us financially from year to year. And if you look at that over the 18,000 people in the county, that's about $50 a head in terms of tax support. So I'd like to say we're a bargain. It may not always feel that way, but I think we are. The foundation support of $280,000 last year. So they buy a lot of equipment to help make sure that we're up to date. As I mentioned, the net revenue of about $68 million. The salaries of $28 million. That's a lot of money going into the local economy. And if we have to reduce services, or if, God forbid, we would ever have to close, almost all of those salaries would go out of the community. Medicare is 52% of net revenue. Medicaid is 10% of net revenue. And then charity care over $250,000 a year. which is a pretty significant part of what we're doing. We do try and get people qualified for services, but it is a significant part. Next slide, please. When you look at what activity, what's a typical day at the hospital look like? Usually around a dozen inpatients, so not breaking at the gills, but that's okay. That means we're keeping people healthy. Last year we had 153 births, so it was a big year for us. ER visits of 5,000, surgeries of 3,000. Last year we had an 11% increase. The year before we had more than a 10% increase. The year before that we had more than a 10% increase in surgeries. And this year, again, we're seeing more than a 10% increase in surgeries. So our ORs are really rocking. And then lab and imaging studies, increases in both of those. Next slide, please. That one, I didn't realize it until it came up on this particular screen. This screen doesn't like that slide. So the general idea is, overall, we want to be a safe hospital for our workers and for our patients. We want to be effective. That means we want to do everything possible and everything reasonable in our area, and then connected to each other as co-workers, with our patients, and with our community. So we can do next slide. And then our goals include patient satisfaction, providing training for our employees, and setting a great environment for patients to heal. We want to be in that top 10% long-term of patient satisfaction. We do satisfaction surveys just like every other business in the world these days. And so we want to score very well, because if you score us well, it means you like the providers that are taking care of you, you trust them, and you believe that they have your best interests at heart. And that's what I believe is overwhelmingly the experience of folks who come to our facilities. And there's that old other saw too of, if you like a service, you'll tell 2 people, and if you don't like a service, you'll get on Facebook and tell 1,000. So, I mean, that's another reason we want to be high in patient satisfaction. Employee retention, we want to keep our great local employees and prepare them for future success. And our goal is to have more than 80% employee retention versus less than 75% nationally. So you have a lot of employee turnover. You have people, you have gaps, you have people working next to you that you don't know, and then there's lots of overtime and lots of additional stressors when you have to bring in new people all the time. So we want to keep the folks that we grow here locally. I'll give you an example of someone that we have grown locally, Becky, who started out in environmental services as a housekeeper, and she, not long after I joined, she came up to me and said, how do I get to patient care? I want to take care of patients. I want to do that. So after a little while, we found a way to get her into a certified nurse aide class, and we helped her pay for that. And then she worked there for a while, and I want to do more. I want to do more. And so right now, she's training in to be one of our surgical techs. So there are a lot of people that we want to keep growing. Oh, and by the way, she brought her daughter in to start in housekeeping too. And so her daughter's been working as a housekeeper after school on the evening shift. So it's that kind of thing. We want to grow our own. If people are already here, they have a reason to stay here. We want to keep growing them like that. I had another employee who started out in our food service, and she said, I want to take care of patients too. And so she is now working as a phlebotomist. Just absolutely loves it. Imagine enjoying your job as a phlebotomist. You literally hurt everyone you meet. But she's not sadistic. She just really wants to take exceptional care of people when she's the one who's drawing blood. We want to have a safe environment. We want to protect our patients and our workers. A couple of years ago, there was someone who slid on the ice in the parking lot. There was a patch of ice about that big, and somehow she found her way to it, fell and broke her hip, and that nurse was out for more than 6 months, cost the hospital $250,000. It's just one of those things. If we can prevent it, we want to do that. So when you look at what's happening in that area as well, one of the cost pressures is the fact that we've had employee health care needs. that were exceptional this last year. So not looking down on folks who have healthcare needs, because it'll be my turn soon, I'm pretty sure. But when you have $1 million unbudgeted health insurance expense over a course of 2 months, it's something that puts a lot of pressure on the finances as well. So we want to keep people healthy in our own group as well as others. And then financial outcomes. We want to have great financial stewardship for our future. Next slide, please. And so what are we doing about this? I talked about these challenges, these stressors on the hospital. We are taking action now to prepare for success. We're recruiting and growing new physician practices. So we brought on 8 physicians in the past couple of years since I've gotten there, and it includes general surgery, 2 OBGYNs, 2 internal medicine docs, 2 family practitioners, and an orthopedic surgeon. So we are trying to grow the services that are available locally. We're bringing on new computer software for efficiency and detailed reporting for other improvements. It's something that we're very keen on doing, is making sure we understand all the data coming in so that we can learn and grow. Careful attention to revenue cycle and expenses. We're going to be engaging some national level hospital finance consultants to help make sure we make good decisions going forward. And our growing practices, as I mentioned, general surgery, OB, primary care, hospitalists, and ED physicians. I mentioned that we continue to grow and remodel and prepare for the future on our facilities, and we have a number of plans for how we're going to continue to grow going into the future. And we're continuing to plan for space and equipment to care for our community. Next slide, please. I mentioned our several clinics, and we do have several clinics throughout the county. So we have the hospital building, of course. We have clinics on the hospital campus that include the Pine Grove Medical Center. So we have internal medicine physicians there, and we have a very busy neurology clinic, as I mentioned there before. Bloomsdale Medical Center and walk-in clinic. So at Bloomsdale, we have a number of services. We have internal medicine, family practice, obstetrics, general surgery and breast care, OB, several nurse practitioners, pediatrics, the walk-in clinic, as I mentioned, and a retail pharmacy. In Apple Kids Medical, we have not only the pediatrician clinic, but we also have rheumatology, and I think we have podiatry in there as well, and ENT. So that's a busy clinic. Point-based, we've got family practice, and that's where most of our specialist physicians come in. So rheumatology and pulmonology and several other specialists come in there. The Sherrill Surgical Clinic, they're busted at the seams with great providers. We've got 2 surgeons in that clinic and several nurse practitioners that specialize. And then the Plaza Family Health Walk-in Clinic, we've got them next to Country Mart, and they see patients 5 days a week. Next slide, please. So we do have continuing plans for how we're going to grow and expand and make use of the old medical surgical unit, as well as growing on campus where we can. And we're going to keep growing. Next slide, please. We do have a lot of connections with the community, and this is one of the really fun things. So this particular event is a lot of fun. This is the backpacks that we pass out to the school kids every August. And so we work with other community partners to gather the materials that go in the backpacks. And last year we passed out over 200 backpacks to people so that their kids had what they needed to go to school. Next slide, please. Food is Medicine program. That's something that we've been working with grant funding and other local partners. So with Country Mart, with St. Vincent de Paul, and with other partners. So what we found is there are some people that are on the verge of going into diabetes, needing medication support for diabetes. And so what we do is we meet with those, a small group of folks like that, a half a dozen or so as a group. We give them extra clinic visits. Then we also do other things like have cooking classes, and then we have a prescription program for 2 fruits and 3 vegetables. And then we have cooking classes that teach them how to use it, because if you just go up and plop a zucchini on somebody's counter and say, "Here, go be healthy," and they look at it and say, "What am I going to do with this? I don't know how to cook this. Do I slice it? Do I fry it? Do I chop it? Do I eat it with liver dumplings? What do I do with this?" And so that's what we're trying to help them become more healthy. And so at the time, we've done a couple of small cohorts of that, and working with a really dedicated nurse practitioner, Ricky Schaefer in Bloomsdale. And 4 out of 5 people in each of those cohorts has been able to reduce their diabetes markers to the point where they don't need to go on medication. This includes a woman who was having a really tough financial circumstance and was living out of her car at the time. So, and we were helping her try and find some other resources there as well. Don't look at the Lay's potato chips in the buggy. That's not Sheila's fault. She was in the car. Okay, next slide, please. Parish nurse program. So one of the things we're trying to do is find ways to make connections that are natural connections with people in the community. So we've got a lot of nurses who have been in the community for a long time, who live in the community. And once you're a nurse, you're always a nurse, because if your friends know you're a nurse, they're going to say, "Hey, what about this rash? Is this something I need to do something more about?" And so I thought, let's take advantage of that. Parish nurse program is something that's been around for more than 30 years. The idea is that we're teaming up, we're starting with St. Genevieve Catholic Church, and we're teaming up with the RNs who either work for the hospital or are just part of the parish. And we're doing things like blood pressure checks after Mass. We're going to do a medication check, so we're going to ask people to bring in all their medications after Mass and say, "Okay, do you know what this medication is for? Do you know that this supplement that you're taking as a dietary supplement interferes with your medication? Did you tell your doctor this?" Trying to find more ways to make those connections. First blood pressure check we did, we got several clinic appointments out of it because they said, "You might want to go see a doctor sooner rather than later." So we started with them because it's the biggest organization in the county. And so at the last parish nurse meeting, we had folks from the Presbyterian Church and the Baptist Church, and we're going to continue to expand that. But we just had an easy starting point. Next slide, please. Walkable community. One of the challenges that people can have, even in a small community, is where can I walk safely? And so we've been working with the National Park Service and the city to try and repair the sidewalks in town and get new walkways to some of our national historic sites so that it's easier to have a healthy lifestyle that includes walking where you're intending to go instead of always taking your car. We even did that on our own campus. As you can see this nice walkway here, this is because Dr. Charlot heard some of the OR nurses talking, and when they're coming in at that dark 30 time that they're getting ready for surgery, wearing those fashionably dark clothes, a couple of nurses said, "I almost got hit when I was crossing the road. Someone came zooming through." So we went to the city, and in partnership with the city, we got a lighted sign and that little posted meeting. If you've ever driven by that lately, you can see that some people have been using it to whack more than avoid. I don't think it's just on Cataract Day, but it's looking pretty rough. But that just proves that we did have a need for it. But we are committed to the safety of our employees and a more walkable community as well. Next slide, please. And we're making other connections with the community, and this is another example. So no matter what our docs do, they're not dentists. And that was something that was showing up as a deficit that we thought that we could close. We found out that the Archdiocese of St. Louis has a free dental van with volunteers. And so once every 3 months, the Archdiocese brings their van out, brings their volunteers out, parks it at Bloomsdale, and then they give free dental care. So there are some people that may have had years or decades of having tooth problems. And sometimes if you get an infection in your tooth, it can go down into your heart. That's one of the things that killed George Washington, by the way. He had chronic infections in his mouth and went down into his chest. That's a story for later. They bring these folks in and they'll do as much dental repair as they need to get them safe and healthy. And it may be several hours, but then they're done, they're fixed. And so we're really pleased to be able to work with them to do that. We're doing other things as well. Mary Bleckler, who is blessedly helping me out with the slide deck, is doing a lot of things in the community. She's got a lot of these programs. And one we found out just recently is there is a program to help people who are in county jails qualify for Medicaid when they're released. And so when you look at one of the reasons that people have trouble adapting to society when they get back in, they don't have financial resources, they don't have access to health care, they don't have access to behavioral health issues, to behavioral health resources. And so this is one more way we can help our community, help people get on the right track. Every way we can find to do that, we're going to do what we can to find a way to do that. Okay. Next slide. So our commitment, we're committed to the community. St. Genevieve is our community. This county is where we grew up, where we get support, and where we live. And we want it to continue to succeed and be healthy as an organization. To the community and independence, because that's the board's mandate and expectation, and we're going to do everything we can to meet that. We recruited several physicians over the last 2 years, and we've had other growth of services. The Meditech upgrade of patient care, so that's the computer system that we're bringing on. We're committed to our future with a master facility plan. We're going to keep our facility current. We're preparing new providers, new services, new procedures, new tools all the time. And we're committed to our goals of being safe, effective, and connected. And we need your support to serve the community in years to come. Next slide, please. So how do you do that? Please choose us for the services we offer. Reach out to us if you're not sure. If we do this locally, if you think there's something else we should do, contact me. I'm always interested in finding out what we can do more or better. If you think, please support our fundraising efforts. This year it's going to be our Golf Classic, our Ride to Survive, and auxiliary events. And our financial donations are used to support new facilities, equipment, and patient care, so we're always ready to take care of you and your family. And I actually had you on the slide last time too, so I'm calling you out, Terry. Next slide, please. So with our Friends and Auxiliary, the Friends Foundation is a connection to the community. There's a 12-member board. The Gala, Ride, Taste of St. Genevieve County, and golf events and other things. And over $1 million donated since its founding. So we're very pleased to have their help and support. And the Auxiliary is more of an internal volunteer group. 160 total volunteers and 55 are very active. Did I get that right, Naomi? Okay. 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 They serve as greeter, gift shop quilters, and many other roles. They're that friendly face at the front of the hospital, and that really is important because you come into a hospital, you're stressed. You don't want to be there anyway, and then you're thinking about what's going to happen next, and then you see that smiling face to greet you and make sure you get where you need to go. That does people a world of good, and we really appreciate that. They do a lot of internal events and sales that benefit the hospital. My wife, who's here tonight, said I needed to bring more of what I bought yesterday at the chocolate and popcorn sale. So next time I'll know what to buy better. So as I mentioned, they're friendly, engaging, and supportive, and typically over $25,000 a year to support equipment usually. Last year, 10,200 hours donated, a $292,000 value by Missouri Volunteer Standards, so we really appreciate what you all do for us. Next slide. So upcoming things that you can do include the Women's Health Fair on February 24th. That's going to be a lot of fun. The Friends Golf Classic in June 28th. The Ride to Survive in early September. And the Gala, usually the first weekend in November. All right. I actually got done 5 minutes early. You'll get 5 minutes back depending on how many questions you have. So I would love to answer anything, clarify anything that you're curious about. I've stunned them into silence, Rod.
I might make a point if I can. You talk about the rural hospitals. I had a family member, it's been about a year ago. Anyway, he was in Barnes Hospital, had a major surgery, and he had to go to rehab. And they sent him to a place down the street from the hospital. It was horrible. They got him transferred to St. Genevieve. He loved it.
Good.
And I'm going to give you a quote. I went from the outhouse to the penthouse.
Wow.
That is
Wow.
And he said the food was extremely well.
It
He
is.
complimented St. Gen, and that's from a non-resident of this area. But,
That's wonderful.
Yeah.
I'm really glad to hear that. It must have really been down in the basement of the first floor hospital is the penthouse.
I won't elaborate, but it was very bad. I'll tell you, very bad.
Well, I'm sorry for that part of the experience, but I'm
He
glad
was there
it
a couple of
remained
weeks,
better.
and as family, we're pretty sure he would have probably passed away had he stayed there. He was that bad.
Oh my.
And they got him, and I might add, his niece works at the hospital, very influential in getting him transferred here.
Good.
Thankfully for her. Yep.
Good. Very
That's
good.
Chrissy.
Okay. Good.
Chrissy Maker. Yep.
Yes, ma'am.
It's not named, not today now.
Yeah. I just wanted to point out that it was her leg, not her hip. That she broke.
Oh. Yeah. It's been a couple of years. I've slept twice since then, so sorry. Well, I was trying to protect the innocent by adjusting the story. Yeah.
Steve, you may want to elaborate on the swing bed program, how we go to other hospitals and talk to them before they're released.
Yeah. So that is one of the things we do, especially if we know that we've transferred a patient up to one of the bigger system hospitals. There are things we don't and shouldn't do, and that's okay. We send them to places where they do that all the time. And if we transfer them up, especially, we'll go up and ask about that patient by name and then try and find out what kind of course of rehabilitation they're going to need to get back home. And so Herschel and his crew work with those hospitals. They've got good relationships. And so the folks we know, and then if there are other folks, they participate in that care planning for folks who come from this area who may be appropriate. And so we do look for folks that we can bring back this direction. And often it is a matter of several weeks to get them back all the way to where they can be. And that's exactly what this program was designed to do, and I'm really glad that we can do that. Sometimes it's things like IV therapy. Often it's physical rehabilitation, so PT and occupational therapy to do that. So, yes, sir.
Yeah, I have just one comment and a question. So we are vendors at the hospital. We spent, a fair amount of time at the location here in St. Jan and in Bloomsdale. And one takeaway that I have when I spend time there is everybody seems to be happy that's working there. And that's not what I always experience when I walk into places where people are working. So, I think that just says a lot. Everybody seems to have the spirit of being helpful and glad to be there, and that I just think that goes a long way for creating a good culture. One of the slides you had up there, you talked about Medicare and Medicaid, and I'm curious to know from a financial impact, like how the Medicaid that affects the hospital differently, and then the second part of that is the Medicaid services that you provide here in the St. Jan area, is that more or less than other rural areas? Just curious about that.
Sure. So Medicare is the program that was set up for senior citizens in the 60s, and Medicaid followed fairly close behind for those who are disadvantaged or younger people, usually for younger people who are lower income or who have disabilities. So those are the two general views of the program. Medicare pays a little bit more of the cost of their services than Medicaid. Medicaid, so if Medicare pays 60 or 75% of the cost of the actual cost of the care of those services, Medicaid may pay 35 or 40% of the cost of the care of those services. The one place they do pay a little bit more is for obstetrics and neonatal ICU, because they found if they didn't invest in the neonatal ICU care, then they ended up having children with a lot more medical challenges that are going to impair their lives in the future. In terms of 10% of our revenue, that is less than any other hospital I've worked with. Just the nature of the county, the average income of the county here is higher than the average income in the state of Missouri. So I think people are generally better off here. There is less need for Medicaid here than there is in other counties. I know that sounds a little crazy because everybody knows somebody who's struggling financially, but when you look at the overall income of the county, there's less of that here. Medicaid expansion affected us less here because when you look at the amount of charity care we do over the past couple of years, we have a lot less of that than, frankly, just about any other place I've been, just because, once again, the average income and so many people have private insurance compared to any place else I've been. Very good question. Any other questions?
Just a comment. The map that you showed of the county of most people we serve, but if you're at the information desk, you realize that people come from Farmington, Perryville, Potosi, Festus, all around, and they love our hospital best.
I will say the last year, I've had a lot more people say, how do you get to here? I've never been to this hospital before. I've only come to St. Jen for a restaurant once or twice, and now I'm moving my care here. So I think that, to your point, I think that people are starting to come to us from those other places more than they used to. And we welcome them with open arms. We want to take care of as many people as we can.
And I spent some time in your swing bed,
Yes.
in our swing bed, and got very good.
Well, we're glad that we can take care of you for a little while. And you've done a lot of things to take care of us, so we really appreciate you.
I have to compliment the people. I mean, you can walk in there and they make you feel like a queen walking. I mean, they are just, they're fantastic. They are great. And I love, that's why you can ask him, I love going, I call it work, going to volunteer, because I feel like they appreciate me being there. They're just, I mean, I've never seen one bad person in that house. And I have to compliment them because they are great. And they treat me like that, but they treat the patients and everybody. I mean, yeah.
Well, thank you for those comments. I have to tell you, it's really heartening to hear that good stuff. One of the challenges of being in my role is I'm always looking for what we can do more, what we can do better, how we can improve. And it does me a lot of good to be reminded of how much good is actually already happening there. So thank you for bringing those kind words forward. All right. Any other comments or questions? Well, I kept it to under the hour and a half, so you get to enjoy the rest of the evening. Thank you so much for coming out tonight. I hope this was useful to you. If there are other questions, please don't hesitate to reach out. We'd love to help you know more about us. Thank you very much.
Thank you.